Good morning, everyone. Let me introduce my PhD topic, which is impact of new genomic technologies on patient care. My name is Csendes. I'm a clinical geneticist resident. I work at the Institute of Genomic Medicine and Rare Disorders. My vision is to boost the effective utilization of genomic technologies, and my mission is to recommend, develop, support educational and financial policies. To achieve that, I have two ongoing projects. My first project is investigating the functional ability of patients before and after Spinraza treatment in spinal muscular atrophy. Spinal muscular atrophy, SMA, is a progressive hereditary neuromuscular disorder which results from the loss of the SMN1 gene, which leads to several muscle weakness and atrophy. Without adequate treatment, it can be lethal under age of 2. So it is no wonder it is the most common genetic cause of infant mortality, with an incidence of approximately 1 in 10,000 live births. Fortunately, within the last year, 2 disease-modifying therapies, Spinraza and Evrysdi, and 1 gene therapy, Zolgensma, have been approved for use in SMA. Within our initial study, we will exclusively focusing on Spinraza, as a significant amount of eligible articles only accessible for this medication. Approved in 2016, Spinraza became the first treatment for SMA. Administered via intrathecal injection, it is a lifelong and extremely high-cost therapy. There are 4 types of SMA based on the onset of the disease and the severity of the symptoms. Alternatively, SMA can be divided based on the functional abilities of the patient at their time of their diagnosis, so namely non-sitters, sitters, and walkers. Previous meta-analysis used the traditional classification. However, we were going to use the aforementioned classification. Why? Because it correlates better with the outcomes to be examined and reflects the variability and therapeutic response in a more efficient way. Our aim is to investigate the effectiveness of Spinraza with different functional abilities. Which leads to our question, how does the functional ability of the patients with SMA influence the effectiveness of Spinraza? To answer our question, we set up a PICO framework. Our population is non-sitter, sitter, and walker patient. Our intervention is after Spinraza treatment, our comparator is before Spinraza treatment, and we would like to measure effectiveness and safety. Our hypothesis is that the clinical effectiveness of Spinraza significantly depends on the functional ability of the patients. And with our study, we would like to emphasize the importance of early identification and prompt initiation of approved therapies. We conducted a systematic search in 3 databases. Here you can see the finalized search key for that. After the systematic search, we got around 4,000 articles, and after the selection process, we ended up 17 eligible full text. We have multiple outcomes, including 2 finished plots regarding the 1-year change in 2 motor function scores, and we have several ongoing analyses as well. On the first forest plot, you can see the 1-year change in motor function based on the Hammersmith Functional Motor Scale. This scale assesses the patient's ability to perform various activities, total score ranging from 0 to 66. 66 means that the patient's functional ability resembles that of a healthy person, and 0 indicates inability to perform any activities. The figure clearly shows that the population is heterogeneous. For the statistical analysis, we used mean difference. In the walker subgroup, the mean difference was 2.99, and in the sitter subgroup, the mean difference was 2.84. Although the effect of Spinraza is small, it is clinically relevant for the individual patients. Another noteworthy conclusion is that the patient's functional ability does not impact the effect of the Spinraza. On the second forest plot, you can see the 1-year change in motor function based on the revised upper limb module. This score assesses specifically the upper limb function of the patients, total score ranging from 0 to 37. 37 means that the patient's functional ability resembles that of a healthy person, and 0 indicates no upper limb function. Once again, for the statistical analysis, we used mean difference. In the walker subgroup, the mean difference was 0.33, which is not clinically relevant. And in the sitter subgroup, the mean difference was 1.06, showing a clear tendency for improvement. With additional articles, the mathematical significance definitely can emerge. Although a 1-point change might seem clinically insignificant, for a patient, it means that they are able to raise a cup to their mouth. Without any treatment, the patient's condition would deteriorate, so any improvement is considered as a success. Our study has its strength and limitation. One of the limitations is a detailed subgroup analysis regarding the non-sitter, sitter, and walker division. On the other hand, this is our limitation as well, because due to the different classification in previous studies, not all the data can unfortunately be assessed. Here you can see the progress of my first project. We are finalized the risk of bias assessment and currently working on the figures. Now let's continue with my second project, investigating the effect of approved treatments for spinal muscular atrophy on the patient's healthcare needs. Before the era of disease-modifying therapy, best supportive care was the gold standard for spinal muscular atrophy. It is a comprehensive and multidisciplinary approach that aims to address the various aspects of the disease. The key elements are nutritional and respiratory support, orthopedic care, and rehabilitative services. I already mentioned to you and introduced to you the approved treatments, Spinraza, Evrysdi, and Zolgensma. It is important that today's days, treatments must be provided alongside the best supportive care. Managing the symptoms of SMA often requires a large amount of healthcare resources. The healthcare needs of the SMA patients, including individualized, precisely designed rehabilitative and palliative care, which comes with a substantial cost. Unfortunately, there is a limited information of healthcare resources utilization. However, it would be essential for adequately designing public policies and funding decisions. It is more relevant in the current scenario with emerging therapeutic approaches. Our aim is to investigate the effect of addition of Spinraza, Evrysdi, and Zolgensma on the healthcare needs compared to the best supportive care. Which leads to our question, how does the addition of Spinraza, Evrysdi, or Zolgensma influence the healthcare needs compared to the best supportive care only? To answer our question, we set up a PICO framework once again. We would like to compare the best supportive care and each and every approved treatment to best supportive care only. And we would like to measure the healthcare needs of SMA patients. Our hypothesis is that the addition of Spinraza, Evrysdi, or Zolgensma significantly reduce the healthcare needs compared to the best supportive care only. And hopefully my two projects will contribute to address the different dimension of treatment impact. Allow me to finish my presentation with Peter Drucker's words, the best way to predict the future is to create it. Thank you so much for your attention.
Thank you for your nice presentations. So we know that the SMA and the gene therapies are a really hot topic nowadays. Can you tell us a little more details about the approved therapies? How do they work? How are they administered, please?
Yes, thank you for your question. So basically, Spinraza and Evrysdi modifies the RNA splicing, basically, and so therefore the SMN2 gene provides more functional full-length SMN protein. Meanwhile, Zolgensma targets the genetic root of the disease. And Zolgensma, it is administered regularly after the loading dose in every 4 months. And meanwhile, Evrysdi has a daily oral dosing, and Zolgensma, it's a one-time therapy.
I was waiting.
Okay.
Thanks for the great presentation. It was a really interesting topic. I just have one question. whether with the data available from the involved studies, will you be able to do like a subgroup analysis on the effectiveness of therapy based on the type of the spinal muscular atrophy, or maybe based on the age of the patients who got the treatment?
It's already a subgroup analysis. Are you asking regarding my first topic?
Yes, I saw actually about the one sitting.
Sorry?
Okay, I saw about the severity of disease, but I meant, will you be able to do it based on the gender and also the type of the SMA?
I mean, the traditional classification is that subgrouping based on the SMA type. So we've done that. We over it at this point. So it is a new way or new approach, basically to subgroup the patients based on their functional ability.
Okay. Okay, thank you.
But what we can definitely, we actually planning to do some adjusted mixed regression, adjusting for age actually, because it can be interesting. We'll see.
Okay, thank you.
Thank you, Barbie, for the excellent presentation. I wanted to ask about your second forest plot. Do you have any idea why was the mean difference so small in the Walker subgroup?
Yes, basically my hypothesis is that due to the so-called ceiling effect, it is basically a well-known phenomenon in the literature. Basically, it is a measurement limitation because the Walker patient already reached a higher score, a higher level of values. So therefore, it's always harder to improve when you are already in a better condition rather than in a poor condition, basically.